Welcome to the Culture of Healthcare Evidence Based Practice, and this is part one in our series. So, in this session, we'll be focusing on the culture of healthcare and what it means to work inside the unique environment of a healthcare setting. We'll explore the expectations placed on professionals, how care is structured and delivered within a practice, and the systems that shape everyday decisions. Along the way, we'll also highlight essential areas such as patient privacy, workplace ethics, and the professional standards that guide behavior in clinical practice. So, this foundation sets the stage for understanding how evidence based practice fits into the bigger picture of healthcare culture. So, we're going to define the key tenets of evidence based medicine, or abbreviated as EBM, throughout this lesson, and its role in the culture of healthcare. So, evidence based medicine emphasizes integrating the best available research, clinical expertise, and patient values. In clinical engineering, this translates to designing, selecting, and maintaining technology based on proven outcomes, not just manufacturer claims or tradition. So, for example, EBM shapes how hospitals adopt medical devices by demanding evidence for safety, reliability, and clinical impact before widespread implementation. This lecture introduces our unit topic, evidence based medicine, or EBM. And evidence based medicine is both a set of tools and a disciplined approach to decision making in healthcare. And at its heart, EBM helps us apply the best available scientific evidence to the wide range of clinical questions that arise every day, whether those questions come from a physician at the bedside, a nurse in a critical care unit, or a clinical engineer that's evaluating medical devices. The goal is to not only seek out the best evidence, but to use it appropriately. For example, when a new medical device is brought into a hospital, the question is not just whether it works in theory, but whether published studies demonstrate its reliability, safety, and effectiveness in real world settings. Clinical engineers often take the lead in this process, using the EBM principles to assess whether the technology improves outcomes or introduces new risks. Now, a caveat in evidence based medicine is the following: the absence of evidence is not the same as evidence of absence. And this phrase, attributed to astrophysicist Martin Rees, is highly relevant to healthcare. Just because research hasn't yet proven a benefit or hasn't revealed a particular risk does not mean that benefit or the risk does not exist. So, in clinical engineering, this principle often applies to emerging technologies. For instance, an innovative diagnostic tool may lack long term safety data. Engineers must consider what is known as much as what is known and unknown. Sorry, that's what I meant. What is known and what is unknown. And they balance this optimism with caution. So, what makes EBM powerful is its ability to integrate the art of medicine, the lived experience of clinicians with the rigor of science. And clinical engineers fit into this equation as well. Their technical expertise becomes part of the decision making process. They ensure that the evidence gathered from studies, pilot testing, and post market surveillance is translated into safe, effective care at the bedside. In this way, evidence based medicine not only strengthens the practice of physicians and nurses, but also empowers clinical engineers to be active participants in the shaping of the culture of healthcare. And I said this many times before, engineering is also, there's also an art side to engineering, the art of engineering. And so you should embrace that. So, what's the big deal about evidence based medicine? Why isn't all of healthcare already evidence based? After all, wouldn't it make sense to always use the best available data? The reality is that human decision making is complicated. In fact, this challenge extends far beyond medicine. Some fascinating insights from Thomas Kita's book, Don't Believe Everything You Think, which outlines 6 ways humans often come to false beliefs. And one of these is our natural tendency to prefer stories over statistics. A dramatic patient story may convince us that a device works wonders, even if the data shows it's unreliable. In clinical engineering, this might look like a department rushing to purchase the latest and greatest imaging system based on compelling anecdotes or vendor promises without carefully weighing the published evidence on its accuracy or failure rates. Another way we go astray is that we often seek to confirm what we already believe instead of just questioning it. A hospital team might assume a long standing piece of equipment is tried and true, but an evidence based review could reveal safety alerts, recalls, or better alternatives. Engineers play a critical role here by asking the tough questions and challenging assumptions with data. Humans also tend to underestimate the role of chance and coincidence. For instance, if a patient's condition improves after a new device is introduced, we may quickly attribute the outcome to the device, even if the improvement was due to natural recovery or another treatment. So, evidence based practice, supported by rigorous testing and clinical trials, helps us separate coincidence from causation. We also struggle with misperceptions. Technology may appear to function well on the surface, but a deeper engineering evaluation might reveal flaws in calibration, software glitches, or risks of misuse. Without careful evidence gathering, those issues could go unnoticed. Another pitfall is our tendency to oversimplify. Healthcare problems are rarely straightforward, and so are the technologies meant to solve them. An infusion pump, for example, might reduce medication errors in one context but create new challenges, such as alarm fatigue. Uh, Evidence based reviews force us to see the full complexity of outcomes, not just the headline benefits. And finally, human memory is unreliable. Clinicians and engineers may recall past experiences with a device inaccurately, perhaps remembering only when it worked smoothly and forgetting when it failed. Evidence carefully documented and critically appraised provides a more reliable foundation than memory alone. This is why EBM matters. It pushes us past the limits of human bias and intuition, giving both clinicians and engineers a disciplined framework to make decisions that truly serve patients and improve safety. In recent years, there has been a growing movement for medicine to be more firmly rooted in evidence. The Institute of Medicine, in its landmark report, Crossing the Quality Chasm, which I'm sure many people know across the industry, it identified effectiveness as one of the six defining attributes of a high quality 21st century healthcare system. That effectiveness is directly tied to the principles of evidence based medicine. Another report in this series introduced the idea of the learning healthcare system, a system where we continuously learn from what we do. The core of this idea is simple: collect data, analyze it, and use those insights to improve practice. While technically this could be done without advanced tools, information systems make the process far more powerful. They allow us to compare data sets, analyze trends over time, and generate insights with much greater speed and accuracy than manual methods ever could. This is where clinical engineering comes in. Engineers are often responsible for the infrastructure that enables this kind of learning: electronic health records, device integration, data monitoring systems, and analytics platforms. For example, a clinical engineer may design systems that automatically capture performance data from infusion pumps or imaging machines, making it easier for clinicians and administrators to see whether a technology is truly improving outcomes or introducing unexpected risks. Improved data analytics capabilities have opened up entirely new ways for us to understand what works and what doesn't. Um, this is especially important in healthcare. So instead of relying on intuition or excuse me, I have a hard time saying certain words. Um, yeah, both clinicians and engineers can base decisions on measurable evidence. And of course, evidence based medicine is not without its challenges like anything else. It involves detailed methodologies for study design, critical appraisal, and statistical interpretation. And these details matter. A poorly designed trial or an incomplete dataset can lead to misleading conclusions. And so, what we're going to do is we're going to touch on some of these methodological issues while more in depth treatments can be found in specialized sources. So, for example, a 2007 supplement to the Journal of Medicare, explores many of the complexities in this sorry, I don't know what I was going to say ethical, and in this evidence-based um, medicine here. And you have a 2015 article in JAMA that's titled "Everything You Ever Wanted to Know About Evidence-Based Medicine." What they do is they distill the key concepts into an accessible overview. So ultimately, whether you're a physician, a nurse, or a clinical engineer, the challenge is the same: to contribute to a healthcare culture where decisions are driven by the best evidence available, supported by systems designed to capture, analyze, and apply that evidence in real time. So, we're going to explore the details of evidence based medicine, but it is important to acknowledge that EBM is not without controversy. In fact, there has been some cultural pushback to the concept. Not everyone fully embraces evidence based medicine, and some clinicians continue to place greater value on experience and direct observation as primary sources of knowledge. After all, medicine has long been considered both a science and an art, and some worry that EBM risks overshadowing the art side. There are also valid criticisms of how evidence based medicine is practiced. One critique is that evidence based medicine can sometimes challenge physician patient autonomy. When guidelines are developed strictly from evidence, it can appear rigid, leaving little room for individual judgment or for the values and preferences of the patients. From a cultural standpoint, this can feel constraining to both providers and patients. I'm sure many of us have felt something similar to this at one point or another. And anyway, I won't get off track. Another concern is that EBM's heavy reliance on large scale randomized controlled trials that can flatten individual differences. So by focusing on population averages, EBM may not always capture the nuances of unique patient cases, especially those with rare conditions, those with multiple comorbidities, or specific cultural and social needs. And finally, there are worries about the manipulation of clinical trial data. Selective reporting, publication bias, or conflicts of interest, all of these can distort the evidence that practitioners rely on. These flaws do not undermine the core principles of EBN itself, but they remind us that in practice, evidence can be incomplete, biased, or even misleading. So, for clinical engineers, these criticisms also resonate. Device evaluations, safety studies, and technology assessments face similar challenges. For example, a randomized trial on a new ventilator may demonstrate effectiveness in control conditions, but engineers must ask, does that data truly reflect real world usage where staff training, maintenance, and patient variability can alter outcomes? So, likewise, engineers must be alert to potential biases in manufacturing, uh, specifically when that has a connection to the supply of the trial data. Uh, and all of this affects the post market surveillance reports. Recognizing these criticisms does not diminish the importance of EBM. Instead, it highlights the need for a balanced approach, a vigilant, balanced approach, and one that values rigorous evidence, but also respects clinical judgment, patient individuality, and the realities of technology in practice. So, for clinical engineers, it reinforces the importance of critical thinking, vigilance, and transparency when applying evidence to healthcare systems. One of the emerging priorities within evidence-based medicine community is the comparative effectiveness research, often referred to as CER. So, like healthcare information technology, CER rose to national prominence during the American Recovery and Reinvestment Act, or the ARA. Beyond its heavy investments in health IT, ARA actually allocated $1.1 billion specifically for CER. The legislation also required two reports to guide how CER would be implemented. And these reports, both published in June 2009, came from the Federal Coordinating Council for CER and the Institute of Medicine. The Federal Coordinating Council's report offered a formal definition of comparative effectiveness research, which we'll cover shortly. More importantly, the report emphasized that CER is not just about research itself. It's also depends on building the ecosystem around it. And that means human capital, training experts who can design and conduct CER, also things like scientific methodology, refining the tools to compare treatments, devices, and healthcare strategies rigorously. Data infrastructure, right? So developing registries, data warehouses, and electronic sources to make comparisons possible. And then dissemination mechanisms, ensuring that CER findings reach decision makers, clinicians, patients, and policymakers in a usable way. And at the same time, the Institute of Medicine published a report prioritizing 100 key research objectives. And these covered not only common diseases that consume vast healthcare resources, but also critical questions that healthcare delivery and persistent healthcare that shows persistent health disparities. So for clinical engineering, CER is especially relevant. Many CER studies go beyond drugs and procedures to evaluate technologies and devices, asking, for example, whether one imaging system provides better diagnostic accuracy than another, or whether a new monitoring device truly improves patient outcomes compared to standard equipment. So, clinical engineers contribute to CER by supplying the technical expertise to assess device performance and safety, helping design data systems. Excuse me, a cough. So, helping design these data systems that capture meaningful device related outcomes. That's important. It's also important to translate CER findings into procurement and maintenance decisions that align with evidence, so that in this way, comparative effectiveness research provides a bridge between large scale scientific evidence and the day to day decisions engineers and clinicians face in selecting, implementing, and sustaining healthcare technology. So if we define CER from an engineering perspective or from a clinical engineering perspective, you can think of comparative effectiveness research as head-to-head testing of what works best under real-world conditions. It's not just about whether a device works in theory, it's about whether it works better than the alternatives in terms of safety, outcomes, cost, usability. For example, does ultrasound System A detect abnormalities more accurately than System B in actual hospital workflows? Does one type of infusion pump reduce medication errors more effectively than another? Which monitoring system leads to fewer false alarms and less alarm fatigue for nursing staff? So CER answers these practical questions by comparing technologies directly using rigorous methods and grounding the results in clinical settings. So for engineers, CER is a tool that connects evidence to procurement, safety, and performance decisions. The Federal Coordinating Council defined comparative effectiveness research, CER, as research that directly compares different interventions and strategies to prevent, diagnose, treat, and monitor health conditions. And the key aspect here is that CER looks at two or more existing treatments or interventions head to head in order to determine their relative effectiveness, their benefits, and risks. So, for instance, a CER might compare two sleep medications directly to see which one performs better under specific conditions. What CER would not do is try to infer results from two separate trials where each medication was only compared to a placebo. The definition also stresses that CER must evaluate a comprehensive array of outcomes for diverse patient populations. That means considering gender differences, ethnic backgrounds, and patients with chronic or multiple conditions that interact in complex ways. In other words, CER is not just about average patients, it's about real patients with real world complexities. From an informatics perspective, CER requires the development and use of large scale data sources, clinical trial databases, electronic health records, patient registries, and the analytic methods to make sense of them. That includes data mining algorithms, predictive analytics, and machine learning approaches. And at the same time, CER must ensure that confidentiality and privacy laws are respected during all this. Further supporting CER is the Affordable Care Act, which established the Patient-Centered Outcomes Research Institute. Uh, and this is an independent organization tasked with advancing and carrying out CERs. And it's unique in that it represents multiple stakeholders, including clinicians, patients, policymakers, and researchers. Its reports and resources are publicly available. You can find them at www.pcori.org. And why does this matter for clinical engineering? Well, engineers often work with devices, technologies that impact prevention, diagnosis, treatment, and monitoring. So CER offers a framework to evaluate those technologies, not just in controlled lab conditions, but in real world hospital environments, comparing them directly to alternatives to determine which best supports patient care. So that is it. Just remember the definition of how engineers would see CER, head-to-head testing of existing technologies. In our next lecture, we'll move from the big picture of evidence-based medicine into its core definitions and practical applications. We'll begin by unpacking what EBM really means in practice. From there, we'll explore the four major types of clinical questions that evidence-based medicine seeks to answer. Questions of intervention, so what treatments or technologies actually work. Questions of diagnosis, how accurate and reliable our tools are for identifying these conditions. Questions of harm, what are the risks, side effects, or unintended consequences? And questions of prognosis, what outcomes can patients expect over time? And once we have this framework, we'll turn to the techniques used to summarize evidence. This includes systematic reviews and meta analysis, which combine the results of multiple studies to provide a clearer, more comprehensive picture of a research topic. For clinical engineers, these summaries are essential when evaluating whether a new medical device or system has enough strong evidence to support safe implementation. And then we're going to look at how evidence is put into practice. This happens through clinical guidelines and decision analysis, which translate research findings into tools that shape everyday care. And for engineers, this means aligning technology choices and maintenance practices with those guidelines, ensuring that the devices in use support, not hinder, evidence based care. So that's about it. That's what we're going to cover next. Uh, and there is where I'll walk us through the nuts and bolts of EBM, the questions it asks, the tools it uses to gather answers, and the way it informs real world decisions, both clinical and technical, inside the healthcare system. This concludes part one of evidence based practice. In summary, evidence based medicine is an approach to decision making that applies the best evidence available to clinical care. It provides a framework for integrating clinical experience, which is the art of medicine, with rigorous science, making the medical literature more relevant and directly applicable to patient care. So, for clinical engineers, this means more than supporting technology. It means ensuring that devices, systems, and processes align with the same evidence based principles by grounding technology decisions in the best available data engineers help create. Right? So, a healthcare environment where science, clinical expertise, and technology all work together to improve safety, quality, and outcomes.